2015 Oral Anticoagulation Update. This presentation was arranged and written by Craig R. Anthony, PharmD, Clinical Pharmacist at Fry Regional Medical Center. The objectives of the presentation are to review the physiology of natural coagulation pathways, to discuss both prophylactic and therapeutic anticoagulation strategies, to discuss the mechanism of action and use of warfarin, to review the mechanism of action and use of recent anticoagulant drug approvals. Definitions used in the presentation: VTE, any thrombus inside the venous circulation; DVT, thrombus formation in a deep vein of the leg, arm, or abdomen; emboli, fragments of a thrombus that dislodge and follow the blood flow, may cause PE, CVA, or arterial thrombus. Anticoagulation, inhibiting thrombus formation by using medications to directly or indirectly inhibit one or more coagulation factors. Anticoagulation may be prophylactic or therapeutic. In looking at anticoagulation therapy, we look at the efficacy and weigh that against the potential complications of the therapy. One of the complications is a bleeding risk factor. For those patients aged 65 years and older, patients who have a history of bleeding, variable INRs, high-intensity anticoagulation, concomitant medications, and alcohol abuse. Also, patients who have a pre-existing medical history of these items listed, or these disease states listed, including anemia, malignancy, trauma, and alcohol. Fluctuations in the INR, sometimes there's an inaccuracy in INR testing. Could be from a change in vitamin K intake or absorption, change in the pharmacokinetics of the actual warfarin medication, or other effects because of the concomitant medication use. Or maybe there's patient noncompliance that's affecting the INR. Changes in clotting factor synthesis. This is a listing of new oral anticoagulants that are now on the market. So we're going to look at some advantages and disadvantages to these new oral anticoagulants. Advantages is that there's a predictable dose response, minimal lab monitoring required, and minimal drug interactions. The disadvantages is that they're costly, there's limited monitoring tests available, bleeding can still occur, there's no antidote readily available, and the new medications may accumulate, causing impairment for the patient. This is an illustration of the direct thrombin inhibitor, and specifically with Pradaxa. The mechanism of action is to direct thrombin inhibitor in 2010. Okay, the contraindications are active pathological bleeding, serious hypersensitivity, and mechanical prosthetic heart valve. Precautions: it is a bleeding risk. It's not recommended with some heart conditions. Absorption is best with a low gastric pH. Absorption is influenced by proton pump inhibitors, food, and acids in gastric mortality. This is a category C for pregnant women, nursing women. There have been no studies of pediatrics, no studies. There are adjustments in dosing that need to be made for patients with renal dysfunction or hepatic dysfunction. There are considerations. So counseling information: swallow the whole tablet. Increase drug exposure if the capsule is broken, chewed, or emptied. Take with a full glass of water. Skip any missed dose if unable to take in 6 hours of the next scheduled dose. Anticoagulants and medication errors. Anticoagulants result in hundreds of medication errors each year. The contributing factors to medication errors are the multiple strengths available in anticoagulants, the unclear labeling, the high-risk patients, drug interactions, multiple and recent new drug approvals. The coagulation cascade as presented. Anticoagulation is used as a prophylactic, given subcutaneous or as an oral medication, and indicated for the prevention of DVT or PE. As a prophylactic, the doses are lower than the therapeutic. For example, enoxaparin at 40 milligrams subcutaneously daily. Therapeutic anticoagulation as IV, sub-Q, or oral medication. Enoxaparin, which is the generic for Lovenox, as a therapeutic dose is 1 milligram per kilogram subcutaneously every 12 hours. It's indicated for DVT and PE, arterial thrombosis, or thrombus, primary prevention of thromboembolic events in AF. Primary or secondary prevention and history of previous thrombus. Factors potentiating thrombus: stasis, vascular, injury, hypercoagulable conditions. Components of clot formation are vascular, platelets, plasma-mediated hemostasis. There's also a tissue factor that initiates plasma-mediated hemostasis. Factor 11 amplifies the response. Thrombin generation is the key regulatory enzymatic step in hemostasis. Anticoagulants are either injectable or oral. Injectable anticoagulants are heparins, low molecular weight heparins, direct thrombin inhibitors, as are oral anticoagulants, direct thrombin inhibitors, vitamin K antagonists, and direct factor inhibitors. This is an example of an injectable anticoagulant, heparin. There's a low molecular weight heparin. There's also a direct factor inhibitor, and direct thrombin inhibitor. Oral anticoagulants, vitamin K antagonist, warfarin, direct thrombin inhibitor class, and factor XA inhibitor class. So warfarin is widely available for patients age 60 and older. Until recently, it was the only available oral anticoagulant in the United States. The most commonly implicated medication in emergency room hospitalizations of elderly Americans. So let's look at the pros and cons of warfarin. Warfarin is the gold standard in anticoagulants, so providers are very familiar with the medication. There is an antidote available. It has once-a-day dosing. It's inexpensive. The cons, however, is that it has a very narrow therapeutic index, the variable dose response due to genetic and environmental factors. There are many drug interactions, frequent dose changes, invasive monitoring, and there are many strengths available. The initial procoagulant effect. The mechanism of warfarin is that it inhibits vitamin K epoxide reductase. It prevents conversion of vitamin K to active form. It affects production of clotting factors 2, 7, 9, and 10. Warfarin may be highly variable and change frequently. Time to and from clinical effect depends on elimination of effective factors. The bleeding risk factor is again for those patients age 65 and older, those patients who have a history of bleeding, variable INRs, high intensity anticoagulation, concomitant medications, and alcohol abuse, and those who have a pre-existing medical history of certain conditions as these listed. Warfarin dosing and warfarin medication therapy is monitored by INR that provides a standardization between labs. Frequent INR monitoring is required, and a look at the INR ranges. Normal is 1, the usual target range is between 2 to 3, and intensive target range 2.5. INR levels may be monitored on an inpatient or outpatient basis. At-home INR testing is now available. So, as far as interactions, there's more than 200 drugs that have a potential for interacting with warfarin. As far as diseases, it increased the effects of different diseases, hepatic dysfunction, hypermetabolic states. And as far as diet, any dietary change, there needs to be more frequent INR monitoring because of the potential interactions. This is a list of some medications that have a potential for interacting with warfarin. Tamoxifen is actually contraindicated with a patient who is using warfarin. Amiodarone, NSAIDs, antibiotics, antifungals, selective serotonin reuptake inhibitors, statins, multiple chemotherapy agents, and so on. So some dietary supplements are also contraindicated or have a potential for interaction with warfarin. Examples are ginkgo, St. John's wort, green tea, and garlic, chamomile, and others are also have the potential. Let's take a look at warfarin in the diet. There's the myth that the patient shouldn't eat green leafy vegetables, but the fact is that foods with vitamin K may be consistently consumed. Also, as far as alcohol is concerned, it increases the warfarin effects at large doses. Okay, so to stop warfarin, vitamin K is an antidote. 5 milligrams of oral vitamin K equals 1 milligram of the IV. So it's mixed in 50 mils and infused over more than at least 20 minutes or more. There's clotting factor concentrates and prothrombin complex. So special populations, those who are pregnant, nursing mothers, those who have renal dysfunctions or hepatic dysfunction should use caution, or warfarin is contraindicated with special populations. Warfarin counseling points, the patient should report any unusual signs or symptoms of bleeding. Also report any black or tarry stools, which may be a sign of the bleeding, bruises that don't heal or bruises that increase in size, bleeding gums. Warfarin should be taken at the same time each day. Do not start or stop any prescription or over-the-counter meds without letting the prescriber or the physician know. Warfarin should be stored out of the reach of children, and the patient should seek medical attention for any falls. Avoid NSAIDs for pain, fever treatment. Acetaminophen is over-the-counter drug of choice. So the patient should be able to use acetaminophen or Tylenol, not the NSAID. Fill all prescriptions at one location if possible. Multiple strengths and colors are available doses. Okay, so Xarelto was approved in 2011. Eliquis was approved in 2012. Perioperative management. In patients with high bleeding risks, oral anticoagulants should be temporarily stopped prior to elective invasive procedures. The therapy interruption may increase clots. Minor invasive procedures with low bleeding risk, residual anticoagulant effects may be acceptable. Major procedures with high bleeding risk, residual anticoagulant effects are unacceptable. Patients at high risk for thromboembolism consider therapies with short half-lives and rapid onset offset of activity, such as low molecular weight